Chapter 3. Falls and drop attacks. Falls and drop attacks. Introduction. Falling in childhood is part of growing up and usually medically insignificant, unless a serious childhood illness contributes. With advancing age, the potential for injury and other complications increases, and falling eventually develops into a dangerous burden for the elderly and the neurologically impaired. Quality of life can be severely affected by associated morbidity, immobilization, fear of falling, FOF, and growing dependency. Despite improved understanding of falls and their prevention, they remain a leading public health problem. The 2014 Behavioral Risk Factor Surveillance System, BRFSS, estimated that more than a fourth of adults older than 65 years have fallen, resulting in 29 million annual falls, more than 7 million injuries, and 800,000 hospital admissions in the United States. The corresponding cost to Medicare alone exceeded $31 billion and $50 billion for all medical care. Centers for Disease Control and Prevention, 2017, August 17. Fall-related injuries belong to the 20 most costly medical conditions. Clinically, a large number of etiologies of falls have to be considered. A useful initial approach is to determine whether a patient has suffered a drop attack or an accidental fall. In this discussion, the term drop attack describes a sudden fall occurring without a prodrome that may or may not be associated with loss of consciousness and cannot be prevented by assistive devices. In contrast, falls reflect an inability to remain upright during a postural challenge. Potential etiologies of drop attacks include cardiac, epileptic, vascular, sleep, and vestibular disorders, as well as congenital brain abnormalities and intracranial masses. In neurological practice, falling is most commonly associated with chronic disorders such as neuropathies, stroke, multiple sclerosis, MS, Parkinsonism, and dementia. Affected patients have impaired control of stability and gait due to functional declines in neuromuscular, sensory, vestibulocerebellar, and cognitive systems. Finally, the elderly, with their inevitable infirmities and accumulating functional deficits, frequently fall. These associations permit a classification of falls and drop attacks, as presented in Box 3.1. As is true for most neurological presentations, the medical history is essential in establishing the likely etiology of a patient's fall. Aside from gender, age, medications, and neurological conditions, which all affect fall risk, answers to the following questions should be sought. What were the circumstances of the fall and has the patient fallen before? Did the patient lose consciousness? If so, for how long? Did lightheadedness, vertiginous sensations, or palpitations precede the event? Is there a history of a seizure disorder, startle sensitivity, excessive daytime sleepiness, or falls precipitated by strong emotions? Does the patient have headaches or migraine attacks associated with weakness? Does the patient have vascular risk factors, and were their previous symptoms suggestive of transient ischemic attacks, TIAs? Are there symptoms of sensory loss, limb weakness, or stiffness? Is there a history of visual impairment, hearing loss, vertigo, or tinnitus? The neurological examination identifies predisposing functional deficits. However, in the case of drop attacks, the examination is often normal, posing a diagnostic challenge. In such patients, neuroimaging is necessary. Further workup is tailored to the clinical circumstance and may include vascular imaging, cardiac and autonomic studies, electroencephalogram, EEG, nocturnal polysomnography, and, rarely, genetic and metabolic testing when related conditions are suspected. Psychogenic disorders of station and gait need to be considered in patients who frequently experience near falls without injuries. Drop attacks with loss of consciousness. Syncope. The manifestations and causes of syncope are described in Chapter 2. Severe ventricular arrhythmias and hypotension lead to cephalic ischemia and falling. With sudden onset third-degree heart block, Stokes-Adams attack, the patient loses consciousness and falls without warning. Other causes of decreased cardiac output, such as bradyarrhythmias or tachyarrhythmias, are believed to be associated with prodromal faintness. However, reliance on history to determine a cardiac etiology of a fall may be inadequate because elderly patients with sick sinus syndrome can be amnestic for presyncopal symptoms. When occurring in young athletes, exertional drop attacks indicate the presence of potentially life-threatening structural heart disease, including aortic stenosis or right ventricular dysplasia, among others. A large atrial myxoma can present in the same manner. Cerebral hypoperfusion due to peripheral loss of vascular tone, orthostasis, is usually identifiable by a presyncopal syndrome of progressive lightheadedness, faintness, dimming of vision, and rubbery feeling legs. But even in the context of positive tilt table testing, up to 37% of patients report a clinically misleading symptom of true cardiogenic vertigo. Newman-Toker et al. 2008. Vertigo and downbeat nystagmus may also occur with asystole. Choi et al. 2010. Seizures. Epileptic drop attacks are caused by several mechanisms, including asymmetrical tonic contractions of limb and axial muscles, loss of tone of postural muscles, atonic seizures, and seizure-related cardiac arrhythmias. Video EEG monitoring of epileptic patients with a history of falls permits characterization of the various motor phenomena that cause loss of posture. Pediatric epileptic encephalopathy syndromes, e.g., Lennox-Gastaut syndrome and Dravet syndrome, as well as the myoclonic epilepsies, frequently present as drop attacks. A tilt table test should be considered in children and adolescents to avoid overdiagnosing epilepsy. Sabri, Mahmoodian, and Sadri, 2006. Epileptic drops in young patients with epileptic encephalopathy syndromes can be reduced with vagal nerve stimulation in some, as well as with clobazam, rufinamide, vinstratin and Ing, 2012, and cannabidiol oil, Tila et al. 2018. Medically refractory cases may show improved control of epileptic drops, as well as developmental gains after callosotomy. Ueda, Sood, Asano, Kumar, and Lewitt, 2017. Falling as a consequence of the tonic axial component of startle-induced seizures may be controllable with lamotrigine. Paradoxically, some anti-seizure drugs can precipitate epileptic drop attacks, such as carbamazepine in Rolandic epilepsy. In patients with a history of stroke, falling may be falsely attributed to motor weakness rather than to new-onset seizures. Destabilizing extensor spasms of spasticity can also be difficult to distinguish from focal seizures. Drop attacks without loss of consciousness. Transient ischemic attacks. Drop attacks secondary to TIAs are sudden falls occurring without warning or obvious explanation such as tripping. Loss of consciousness either does not occur or is only momentary. The sensorium and lower limb strength are intact immediately or shortly after the patient hits the ground. Between episodes, the neurological examination should not reveal lower limb motor or sensory dysfunction. The vascular distributions for drop attacks from TIAs are the posterior circulation and the anterior cerebral arteries. Vertebrobasilar insufficiency. Drop attacks caused by posterior circulation insufficiency result from transient ischemia to the corticospinal tracts or the pyramidal reticular formation. They are rarely an isolated manifestation of vertebrobasilar insufficiency, because most patients have a history of TIAs that include the more common signs and symptoms of vertigo, diplopia, ataxia, weakness, and hemisensory loss. Occasionally, however, a drop attack is the ominous precursor of severe neurological deficits due to progressive thrombosis of the basilar artery and may precede permanent ischemic damage only by hours. Aside from embolism and focal stenosis in the posterior circulation, vertebrobasilar insufficiency can also be caused by the subclavian steal syndrome, Osiro S. 2012. Anterior cerebral artery ischemia. Anterior cerebral artery, ACA. Ischemia causes drop attacks by impairing perfusion of the parasagittal premotor and motor cortex controlling the lower extremities. Origination of both ACAs from the same root occurs in approximately 20% of the population and predisposes to ischemic drop attacks from a single embolus. Paraparesis and even tetraparesis can result from simultaneous infarctions in bilateral anterior cerebral artery, ACA, territories, Kong and Kim, 2008. Limb-shaking TIAs can be associated with drop attacks and occur in the context of the same vascular variant described earlier, Gerstner, Liberato, and Wright, 2005. Rare cases of drop attacks arising in the context of carotid dissection, Kasana et al. 2011, and frontal arteriovenous, AV, fistulas, O. Yoon, Kim, and Shim, 2011, have been described. Third, ventricular and posterior fossa abnormalities. Drop attacks can be a manifestation of colloid cysts of the third ventricle, Chiari malformation, Chiari drop attack, or mass lesions within the posterior fossa. With colloid cysts, unprovoked falling is the second most common symptom, after position-induced headaches. This history may be the only clinical clue to the diagnosis because the neurological examination can be entirely normal. Pineal cysts are also an occasional cause of drop attacks by producing a sudden rise in cerebrospinal fluid, CSF, pressure with position-dependent obstruction, ball valve effect, of the ventricular system. Fernandez-Miranda, 2018. Drop attacks occur in 2% to 3% of patients with Chiari malformation and can be associated with loss of consciousness. They often resolve after decompression surgery. Strauss, Foster, Zimmerman, and Frim, 2009. Posterior fossa arachnoid cysts are common but only occasionally associated with tonsillar ectopia. This combination of anomalies has also been reported to cause drop attacks. Killeen, Tromop, Alexander, and Wickremsekera, 2013. Drops induced by rapid head turning were considered pathognomonic of cysticercosis of the fourth ventricle in the early 20th century. Brunstein. The contemporary maneuver of cervical spine manipulation is rarely associated with a drop attack. Sweeney and Doody, 2010. Patients who experience sudden drop attacks in the context of intracranial mass lesions such as parasagittal meningiomas, posterior fossa and foramen magnum tumors, and subdural hematomas usually have baseline abnormalities of gait and strength. Falling may occur consequent to these impairments rather than to acute loss of muscle tone. Otolith crisis. During attacks of vertigo, patients often lose balance and fall. Approximately 1 in 5 patients with peripheral vestibular disorders experience drop attacks. Tomanovich and Bergenius, 2010. Meniere disease, see Chapter 22, may be complicated by vestibular drop attacks. Tumarkin otolithic crisis, Tumarkin, 1936, in approximately 6% of patients. Presumably, stimulation of otolith receptors in the saccule triggers inappropriate postural reflex adjustments via vestibulospinal pathways, resulting in falls without accompanying vertigo. Affected patients report feeling as if, without warning, they are being thrown to the ground. They may fall straight down or be propelled in any direction. Chen, Zhang, and Tumarkin, 2020. One patient reported suddenly seeing and feeling her legs moving forward in front of her as she did a spontaneous backflip. Personal communication Dr. R.B. Darof. Vestibular drop attacks may also occur in elderly patients with unilateral vestibulopathies who do not satisfy diagnostic criteria for Meniere disease. H. Lee, Yi, Lee, An, and Park, 2005. Cataplexy. Cataplexy, the sudden loss of lower limb tone, is part of the tetrad of narcolepsy that also includes excessive daytime sleepiness, hypnagogic hallucinations, and sleep paralysis. See Chapter 101. Consciousness is preserved during a cataplectic attack, and the attack may vary in severity from slight lower limb weakness to generalized incomplete flaccid paralysis with abrupt falling. Once on the ground, the patient is unable to move but continues to breathe. The attacks usually last less than 1 minute, only rarely exceeding several minutes in duration. Cataplectic attacks are provoked by strong emotion and associated with laughter, anger, surprise, or startle. Occasionally they interrupt or follow sexual orgasm. Cataplexy is rarely diagnosed in children, but a characteristic cataplectic facies, with repetitive mouth opening, partial ptosis, and tongue protrusion has been described. Pillen, Pizza, Daunt, Scammell, and Overeem, 2017. During the cataplectic attack, electromyographic silence in antigravity muscles is seen, and deep tendon reflexes and the H reflex cannot be elicited. Cataplexy occurs in the absence of narcolepsy when associated with cerebral disease, symptomatic cataplexy, as in Niemann-Pick disease, Norrie disease, brainstem lesions, or as a paraneoplastic disorder. Farid et al. 2009. It can rarely occur as an isolated problem in normal individuals who have a family history of narcolepsy. Falls. Neuromuscular disorders and myelopathy. All conditions causing sensory and motor impairment in the lower limbs predisposed to falls. Leg weakness, especially of the proximal type, and delayed sensory signals from the lower limbs lead to characteristic gait abnormalities in neuropathies. Wooer et al. 2014. In diabetics, coexisting retinopathy and vestibulopathy further enhance the fall risk. Gioacchini et al. 2018. The multiple causes of neuropathy and myopathy are discussed in chapters 106 and 109. Additional disorders increasing fall risk include lumbosacral radiculopathies, myelopathies, channelopathies associated with intermittent weakness, and neuromuscular transmission disorders. Falling may herald the onset of acute polyneuropathies such as Guillain-Barré syndrome. Patients with spinal cord disease, see Chapter 27, are at particularly high risk of falling because all descending motor and cerebellar tracts and ascending sensory tracts traverse the cord. This is particularly true for multiple sclerosis patients with gait and balance dysfunction, of whom at least half fall once or more a year, Cameron and Nilsegard, 2018. Multiple sclerosis patients older than 55 years have a high rate of injurious falls, Peterson, Cho, von Koch, and Finlayson, 2008, and FOF is common in this group, Calron and Akirn, 2014. However, even elderly multiple sclerosis patients can attain marked reductions in fall risk with home-based balance and strength training. Sosnoff, Finlayson, Macaulay, Morrison, and Model, 2014. Stroke. Strokes present with any combination of neurological deficits that predispose to falls in the acute and chronic state: weakness, ataxia, sensory deafferentation, hemianopsia, diplopia, anosognosia, hemineglect, vestibular tilting, and acquired gait abnormalities, Chen, Novak, and Manner, 2014, are obvious risk-enhancing factors. Post-stroke depression and immobilization further aggravate this risk, which is at least twice as high in stroke patients compared with age-matched controls. The majority of falls occur within the home environment and come with a high risk, greater than 70%, of injuries, Schmid et al., 2013. The post-stroke risk of a hip fracture is doubled and is particularly high in women within 3 months of the ischemic event, Powles et al., 2009. Concerns for such injuries have increased prevention efforts but have also provoked restrictions on patient mobility in acute care and rehabilitation facilities, Inoue, Brown, and Tonetti, 2009, because falls typically occur when patients attempt to get out of bed, stand up, or walk. Fortunately, concerted efforts have yielded significant reductions of fall and injury incidents in such institutions. Services, 2014, May 7. Other cerebral or cerebellar disorders. Metabolic encephalopathies may cause a characteristic transient loss of postural tone, asterixis. If this is extensive and involves the axial musculature, episodic loss of the upright posture can mimic drop attacks in patients with chronic uremia. Cerebellar disease causes truncal instability and represents a prime cause of falling. Patients with degenerative cerebellar ataxias, see Chapter 23, have a 50% incidence of falls in any 3-month period of observation, which correlates with increased gait variability. Schneep et al., 2014. Episodic ataxia syndromes and familial hemiplegic migraine are also associated with recurrent falls. Black, 2006. Severe attacks of hyperekplexia, a familial disorder of increased startle sensitivity, manifest with generalized hypertonia that can lead to uncontrollable falls. Effective prevention with clonazepam or valproate is available. Beneficial treatment can also be offered to properly diagnosed patients with normal pressure hydrocephalus. See Chapter 88. Ventriculoperitoneal shunting leads to dramatic improvement of gait and decreased risk of falls, albeit in a temporally limited manner. Cryptogenic falls in the middle-aged. A diagnostic enigma is the occurrence of falls of unknown etiology among a subset of women older than 40 years of age. The fall usually is forward and occurs without warning during walking. The knees are often bruised. Tice, Blom, and Van Dyke, 2009. Affected women report no loss of consciousness, dizziness, or even a sense of imbalance. They are convinced that they have not tripped but that their legs suddenly gave way. Gait is normal after the fall. This condition is estimated to affect 3% of women and develops after the age of 40 in the majority of patients. Originally described as a disorder of unknown causality, more recent inquiry into the frequency of falls in middle-aged and older women in the general population has elicited fall frequencies from 8% in women in their 40s to 47% in their 70s. Age and number of comorbidities such as diabetes and neuropathies are most predictive of falling. Nitz and Choi, 2008. Vestibular dysfunction of variable severity is also unexpectedly common and can be seen in 35% of individuals older than 40 years. Symptomatic. Dizzy. Patients have a 12-fold increase in the odds of falling. Agrawal, Carey, Della Santina, Schubert, and Miner, 2009. Fibromyalgia is associated with vestibular symptoms and an increased fall frequency. Jones, Horick, Winters Stone, Irvine, and Bennett, 2009. As are migraine. Carvalho et al. 2018. Poor sleep. Colley et al. 2018. Lower limb joint and foot problems. Afrin et al. 2018. And obesity. Yolitalo and Carvanen Gutierrez, 2016. Indeed, obesity is associated with impaired dynamic balance functions already at a young age. Do Nascimento, Silva, dos Santos, de Almeida Ferreira, and de Andrade, 2017. When combined with sarcopenia, a clinically significant loss of muscle bulk and strength that can arise at any age throughout adulthood, the negative impact of obesity on mobility and associated FOF is magnified. Although beneficial in many regards, bariatric surgery has, unfortunately, been shown to increase the risk of fall-related, serious injuries. Carlson et al. 2018. These observations indicate that risk factors for falls are prevalent already in middle age and correlate with falling later in life. Aging, neurodegeneration, and the neural substrate of gait and balance. Significant alterations in quantitative gait characteristics. Chong, Chaston, Welter, and Du, 2009. Evolve with advancing age, even in healthy individuals. It is estimated that by the age of 65, only 1 in 10 persons show gait abnormalities, but by the age of 85, only 1 in 10 have a normal gait. In the future, standardized measurement of gait speed could be included in the routine clinical assessment of the elderly, akin to a vital sign, because slow speed is less than or equal to 0.6 meters sec, has strong predictive power for all-cause mortality. Cummings, Studensky, and Ferrucci, 2014. Modern imaging methods are beginning to reveal the cerebral circuitry and brain centers supporting gait and balance. The midbrain contains a locomotor region within its reticular formation that includes the cholinergic pedunculopontine nucleus, PPN, and the cuneiform nucleus, CN. They are poorly delineated anatomically, but mesencephalic gray matter shows atrophy on magnetic resonance imaging, MRI, morphometry in non-DOPA responsive Parkinsonism associated with gait and balance deficits. Cerebral et al. 2019. The noradrenergic locus ceruleus is coactivated with the PPN, Benerick, 2013, along with extensive pyramidal, extrapyramidal, and transcallosal networks. Cognitive circuitry in the frontal lobe and in the temporoparietal cortex, Takakusaki, 2017, is also involved in gait and balance functions, explaining the link between declining stability and cognition in the elderly, sometimes described as brain failure. As expected, this is accelerated by subcortical white matter ischemic changes in neurodegenerative disorders. Montero Odasso and Hachinsky, 2014, Srikanth et al. 2010. For instance, patients with mild cognitive impairment, MCI, have a nearly threefold prevalence of gait abnormalities compared with healthy older adults. Ilali and Verghese, 2017, and specific spatiotemporal gait features correlate with an increased risk of falls in dementia. Madhuri C., Devine, Gran, Overend, and Hunter, 2018. A clinically useful correlate of the parallel involvement of cognitive and locomotor pathways in the elderly is the failure of dual task execution when walking. Reduction of step length or stoppage when talking, stops walking while talking, is a reliable indicator of an increased fall risk in the elderly. Ayers, Toe, Holzer, and Verghese, 2014. Fear of falling. FOF is a common and serious complication in patients with a history of falls and can also affect those at increased risk for falling. By itself, FOF increases the likelihood of such events, subsequent immobilization, and progression toward end-stage disability. It is not limited to the elderly who have suffered injuries. FOF is prevalent among diabetics. Houston and Deshpande, 2018. Migraineurs, Carvalho et al. 2018. Obese patients, Neri et al. 2017. And those with depression and sarcopenia, Gadea et al. 2018. It tends to affect female patients more severely. Older adults should be queried about possible fear of outdoor falling, because their perceptions about the neighborhood environment can lead to self-imposed mobility restrictions. S. Lee et al. 2018. FOF and its advancing severity in patients with recurrent falls is reliably assessed with the Falls Efficacy Scale I. Gazabara et al. 2019. Brain mechanisms underlying FOF may relate to hypometabolism in the L supplementary motor area, a brain region involved in motor planning. Sakurai et al. 2017. FOF is augmented by underlying anxiety and may evolve into a specific phobia, basiphobia, in some patients, Grenier et al., 2019. Intervention in the form of structured exercise and cognitive behavioral therapy can alleviate the adverse effects of FOF, Wetherell et al., 2018. Liu, Ing, Chung, and Ing, 2018. Basal ganglia disorders, Parkinson disease. Nearly all patients with Parkinson disease, PD, fall over the course of their illness and suffer twice as many fractures as age-matched controls. The fall risk increases with multiple factors, including disease duration, depression, cognitive impairment, treatment-related motor fluctuation, sedating drug use, coexisting rapid eye movement, REM, sleep behavior disorder, RBD, and, especially, cardiovascular autonomic dysfunction with orthostatic hypotension, Romagnolo et al., 2019. In addition, some patients may, without warning, drop directly to the ground. This is most commonly related to dopamine-induced motor fluctuations, particularly peak-dose dyskinesias and off periods, see Chapter 96. Freezing of gait, fog, another fall-promoting feature of PD, shares a pathophysiological link with RBD because both conditions are associated with changes in the mesencephalic locomotor and balance centers, PPN and locus ceruleus, Vodenovich et al., 2013. Fog further correlates with dysfunction in cholinergic striatal pathways, Bonin et al., 2019, while cholinergic dysynervation of cortex relates to slowing of gait in PD, Bonin et al., 2013. Dopamine substitution and deep brain stimulation, DBS, in PD patients improve gait characteristics but have less effect on axial locomotive components, Chaston et al., 2009, such as vertical braking, which corresponds with an individual's ability to control falling. This appears to depend on non-dopaminergic pathways, because PD patients who fall demonstrate cholinergic hypofunction, whereas nigrostriatal dopaminergic activity is the same as in non-fallers. Degeneration of the cholinergic PPN appears to be a key factor for impaired postural control in PD. These findings offer an explanation why standard DBS targeting the subthalamic nucleus does not diminish fall risk. Hausdorff, Grundlinger, Scollins, O'Haron, and Tarsi, 2009, and may actually contribute to an increased fall incidence. Parashos, Wielinski, Galata, Gurevich, and National Parkinson Foundation Quality Improvement Initiative, 2013. DBS of the PPN has yielded variable results with regard to improvement of gait and postural instability. Thivathazan et al., 2012. Although central mechanisms of gait and balance dysfunction predominate in falling PD patients, there is evidence that proprioceptive functions in the lower extremities also may be impaired, augmenting the fall risk. Teasdale, Preston, and Waddington, 2017. Consensus recommendations for fall assessment and prevention in PD patients have been published. Van der Mark et al., 2014. However, falling still remains intractable in many PD patients, and prevention programs have demonstrated only limited and transient benefit. Progressive supranuclear palsy and other Parkinsonian syndromes. Progressive supranuclear palsy, PSP, see Chapter 96, manifests with Parkinsonian features, axial rigidity, spasticity, and ophthalmoparesis. Falling affects all patients early in the course of the illness, Williams, Watt, and Lees, 2006, and is more likely in the backward direction than in those with PD, even with equivalent functional impairment. MRI tractography demonstrates overlapping but also differential involvement of brain circuitry in PD, in Parkinsonism, and in normal elderly, Chan et al., 2014. RBD, see Chapter 101, is a precursor of PSP and an underrecognized cause of nocturnal falls. Clonazepam is commonly effective in the treatment of this parasomnia. Mechanisms similar to those described with PD and PSP contribute to falls in other Parkinsonian syndromes, including multiple system atrophy, corticobasal ganglionic degeneration, and Lewy body disease, see Chapter 96. Falls are highly prevalent in the latter disorder because of the added cognitive dimension of neurological disability. Aged state. Most patients presenting to neurologists with a complaint of falling are elderly and chronically impaired. Approximately one-third of persons older than 65 years fall at least once every year, Centers for Disease and Prevention, 2008. As the likelihood of falling increases with age, so does the severity of injury. Next to fractures, falls are the single most disabling condition leading to admission to long-term care facilities. The increased risk of injuries and fractures with falling is explained by a declining ability to absorb fall energy with the upper extremities, Schran, Stotz, Normandin, and Robinovich, 2010. The diminishing size of soft tissue pads around joints, in particular the hips, and osteoporosis. As would be expected, elderly in sheltered accommodations have the highest frequency of falls, affecting up to 50% every year. Many of these patients fall repeatedly, with women bearing a higher risk than men. Women also experience more FOF and fractures after falling, whereas men are more likely to suffer traumatic brain injury, TBI, and die as a result. Additional gender differences exist in regards to fall circumstances. Men in long-term care facilities are more prone to fall from loss of support from an object and while rising from the seated position. Women are more likely to fall when walking, Yang et al., 2018. The high prevalence of anticoagulant and antiplatelet use in the elderly raises concern about the risk of intracranial bleeding in fall-related TBI. Paradoxically, low-dose aspirin may be protective, Gangavati et al., 2009, but can also cause delayed intracranial bleeding within 12 to 24 hours after head trauma. Tauber, Kohler, Moroder, Hitzel, and Resch, 2009. The presence of an intracranial hemorrhage in conjunction with warfarin use indicates an increased risk for further clinical deterioration, even if the patient is awake upon admission. Howard et al., 2009. Recurrent falls while on anticoagulation do not appear to be associated with an increased bleeding risk, but there is a much greater risk of death if an intracranial hemorrhage or another bleeding injury in a solid organ has occurred. Chu, Jean, Fleming, and Pei, 2018. In very old patients, falls constitute the leading cause of injury-related deaths, with TBI causing at least 1/3 of 15,000 plus fall-related fatalities every year. Complications of hip fractures cause most of the other fatalities. Dupre, 2009. The normal aging process is associated with a decline in multiple physiological functions that diminish the ability to compensate for challenges to the upright posture. Decreased proprioception. Suderlin and Sayer, 2014. Sarcopenia. Schopp, Van Shore, Lips, and Visser, 2018. Orthopedic conditions. Obesity. Follis et al., 2018. Cardiovascular disturbances. Deteriorating visual and vestibular functions. Liston et al., 2014. Cognitive impairment, and failing postural reflexes. Presbyostasis. P.Y. Lee, Gattera, and Bronstein, 2014. Accrue to increase the risk of falling. Table 3.1 contains a steadily growing list of medical conditions that have been shown to increase falling risk in the elderly. Neurological conditions are not listed because all impairments of motor, cerebellar, sensory, and cognitive functions augment a patient's susceptibility to fall. The clinical evaluation aims to determine the fall mechanism and to identify predisposing medical conditions and correctable risk factors. In the absence of an overt explanation for falls, a syncopal event for which the patient may be amnestic becomes more likely. Orthostatic hypotension, Shaw and Clayton, 2014, and blood pressure drops associated with head turning, Schoon et al., 2013, are important contributors to falls but require a detailed evaluation of autonomic functions for adequate diagnosis. However, definitions of orthostasis vary significantly and diminish the relevance of an incidental measurement. Sadin, Tan, and Frith, 2018. A greater than 25% diastolic blood pressure drop is strongly correlated with previous falls, whereas a greater than 25% systolic drop correlates with orthostatic symptoms. Hardig et al., 2017. The implications of severe orthostatic blood pressure dysregulation are dire. Failure of recovery of systolic blood pressure to at least 80% after 1 minute of standing is a strong predictor of mortality in elderly who fall. Lagro et al., 2014. The immense burden of falling to patients and society necessitates recognition of an increased risk of future falls. Detailed practice parameters and guidelines have been published. Society, 2010. Thurman, Stevens, Rao, and Quality Standards Subcommittee of the American Academy of 2008. Intervention for falling elders requires a multifaceted approach. Society, 2010. Tanetti and Kumar, 2010. Depending on the clinical situation, this may include provision of assistive devices, orthotics, canes, and walkers, treatment of orthostasis or cardiac dysrhythmias, and modification of environmental hazards identified during home visits. All unnecessary medications that increase the risk of falls, especially sedatives, antihypertensives, and hypnotics, should be discontinued. High-risk behavior such as the use of ladders and moving about at low levels of illumination is discouraged, and women are advised to wear sturdy, low-heeled shoes. Balance training such as Tai Chi and exercises aimed at improving strength and endurance diminish fall rates. Behavioral intervention for the development of FOF after such events can be effective and is strongly encouraged. Further useful interventions in the long term include vitamin D substitution, greater than 800 international units, IU, per day, improvement of vision with cataract surgery, Fossa et al. 2006, and statin treatment for prevention of osteoporotic fractures. However, none of these measures abolish the risk of falling, and even well-intended interventions may be associated with an increased fall risk. Unexpectedly, this was shown in patients who received new prescription eyeglasses, Campbell, Sanderson, and Robertson, 2010, and for the convenient annual dosing of 500,000 IU of vitamin D, which not only enhanced the risk of falls but also fractures, Sanders et al. 2010. Use of walkers is associated with the highest fall risk, raising the question whether these ubiquitous devices have inherent design flaws that are contributory. Stevens, Thomas, Tay, and Greenspan, 2009. Currently, falls in the elderly remain an intractable problem. Exercise programs have been evaluated extensively, with variably beneficial results in terms of fall rates and cost effectiveness. Hectoan, AAs, and Luris, 2009. Tanetti and Kumar, 2010. Elderly patients with high fall risk and dementia may not benefit at all. Peak et al. 2018, and, unexpectedly, a tendency toward greater rates of hospitalization and death were reported with long-term, greater than 1 year, exercise programs. However, a meta-analysis indicated modest benefits and safety of long-term, moderate-intensity exercise participation, not exceeding 3 sessions per week. DeSuto Barreto, Rolland, Velas, and Malte, 2018. Biomedical engineers are developing devices that aim to diminish falls and their adverse consequences, including sensors on the body, in beds, or in flooring that detect and announce falling. Low-stiffness walking surfaces and soft, protective shells for major joints may reduce the risk of serious injuries. Advances like these, along with screening of elderly persons for fall risk and preventive program enrollment, may eventually diminish the burden of this epidemic.